This is July 14th. Is that where we are, 14th? 2022. And today we have three interesting surgeries. The first one is a thoracic disc herniation at T2-3. This patient has already had a thoracic disc herniation surgery, Deuk laser disc repair, done at T6-7?
5-6.
Sorry, T5-6, and has 100% pain relief from that procedure. So his thoracic pain at T5-6 is gone, and now he has a T2-3 herniation we're going to try to fix. He's had a prior posterior cervical laminectomy and fusion done in the past at C3, 4, 5, 6, 7, T1, T2. He now has what's called adjacent segment disease right below his fusion. So that's the T2-3 herniation we're going to try to fix. Shot. Now, normally we do our thoracic surgeries, our thoracic Deuk laser disc repair with the patient, I think we're a bit overexposed, with the patient awake. But Luis, what is this?
My line is awful.
Huh?
My line is awful, yes.
It's way off.
Yeah, it's very, very.
Okay. Hold on, Monica. Let me just see. I think we're a little bit overexposed. You see this, the T2-3 disc? I think it's a little too bright, just like one notch too bright. But this is pretty close to where we need to be. I think our incision will be somewhere around here. Wait. Shot. So I'm just going to get into it, folks, with my team, and I'll stop and talk to you as I can. But you can see the screws and rods from the prior surgery, and we're going to fix the disc just below that. I think maybe somewhere around here for the numbing medicine. I'm going to give him a little bit of local. You can't really see too much because the x-ray machine is blocking your guys' view, but we're just numbing the skin up, which is standard for spine surgery. Shot. All right. I think that's a pretty good place right there. I have a marker. It's going to be somewhere around there. We'll see. Yeah. And feel the spinous process there. Okay. So to do this surgery, we go in through the back, but not straight in the back. We come off to the side. Since his herniation is a little bit more to the right side and his pain's to the right side, we're going on the right side. We're going to go transforaminal and try to get into the foramen and right into the herniation. Shot. He's going to have a lot of soft tissue before I get down anywhere near the lung field. And we're going to stay behind, hopefully, and medial to the lung field. We have to be prepared for a pneumothorax just in case it happens, which case he would have to be transferred to the hospital. We don't expect that to happen, but it can happen. Shot. And every patient is consented and prepared for that. Let's go with a lateral. Now, to figure out where the disc is that we're fixing, we use an x-ray machine. And we count from where we know the location of the different vertebrae are. So I need to see up a little bit, and I feel like we're underexposed in that dark area where the screws and rods are. We need a little better visualization. You've got a nice, by the way, you've got a nice perfect position there. You don't need to wag because I can see the disc space pretty good. I would like it. It's too light now. So right now I'm talking to my team. We're trying to figure out how to get the best x-ray picture because the x-ray picture is what's going to guide me. I feel like I'm a little bit too low. I want to be a little higher. So I'm going to make some adjustments, and You can see what I'm adjusting right now is my entry point. Shot, is that it? All right, we got to see that disc better at T2-3. All right, just see if you can darken it up a little or get a little bit. I would probably move your fluoro up. I would bring your collimator in and try to sharpen up the picture at T2-3. Yeah, that's not going to help you much. It's the stuff in the back that's overexposing you. So that's good. We're going to use this X-ray machine and try to optimize the picture. I think you're seeing too much of the bottom stuff. It's overexposing you and you're not able to see the disc area properly. Monica, do you understand?
I do. I'm just looking to see where I'm at here with these artboards.
I would move north a little bit, maybe in a little bit. You may have to open your collimator on the right, the back a little bit to see the needle. All right, so what we're doing, folks, is we're moving the X-ray machine, which allows us to see the disc. That's not bad. It's, I think, an improvement in terms of being able to see the end plates a little better. I think we need to drop the fluoro to the ground about 1/2 inch.
Can you bring the table up just a little bit, please? I'm all the way down.
That's it. Shot. Yeah, that's getting better. All right, now if we can just try to improve it a little bit more. Maybe play with the collimator on the bottom and see if you can get rid of some of that white spine, and that may help us see the disc that we're working on. So it's going to take us a few minutes to really get good. Let's see what that does. Don't do too much, just do a little bit, see if it gets better. All right, that's overexposed, so try to reduce the exposure. That's definitely getting better there. That's not terrible there, but we can make it better. It's a little, I need to see that disc space a little better. Do you think we need to wag it? I think you're off on orbit a little bit. If you look at the T3 facets and pedicles, we're off on orbit a little bit. It's too overexposed. I think on the orbit, I'm not sure. I think we might have gone the right way. But you're way overexposed. Huh? I don't know. I need the exposure proper because I can't really see the elements without the exposure being proper. Are you seeing what we're seeing? Are you looking at the end plate and the disc space?
Yes, I see it.
Put your arrow where the end plate and disc space are that we're looking for. Yeah, that right there. So that disc space I need to see as clear as you possibly can get it. So you got to play with the exposure. You got to play with the windowing, with your collimator to find to make it as visible as possible to me. Okay? So while Monica is working on the X-ray machine, see how it's worse? You can't see it? So you're overexposed. Anyway, you're doing pulsing or no pulsing?
No pulsing on this
Why don't you try pulsing, see what happens? I've never seen Jordan not pulse, and he gets good pictures. Pulsing means less radiation, less exposure. And maybe you're already overexposed, so it may help to reduce the exposure. That's a little better. All right, but we're seeing, huh?
Can we move that pointer and
Move the pointer down a little bit so it's out of the, we've got to get that disc space a little better. You see it? Yeah. All right, so while we're working on cleaning up the X-ray picture, and just a word of advice to surgeons who do spine surgery, always get your X-ray picture, your fluoro picture, the best you can with respect to the exposure, how white versus dark. You want to get it as perfect as you can. And yeah, that's better. And then you also, that's pretty darn close to where we need it. That's pretty darn close to where we need it right there. Yeah. If you can make it better, whatever you're doing, if not, we can leave it there and be happy. I would like it a little better. I still think you're a bit overexposed. So my advice again is you must get the x-ray as perfect as humanly possible by adjusting things, moving things, so that you can see your target and you can see the path to the target, okay? Once you're done optimizing, that's pretty good. Once you're done optimizing, then that's when you start navigating. So I'm gonna start navigating at this point and see what happens. Shot. Can you show me a little more on the right side, because I want to see the needle as it approaches. So open up your right collimator just a little bit. That's good. That's good. Don't do any more than that. Shot. All right. So we're still pretty far away. No. I'll bring my needle down a little bit. That's good. Just right there. Take a shot. All right. So let's see what we can do. We're targeting the foramen at T2-3 and the disc. Shot. All right, so I'm too low. Well, it's not too bad, actually, but I would like to be a little bit higher. I want to approach the target a little bit more from the top down. Shot. All right. AP. You'll monitor everything. Yeah, I'm not even close right now. I'm still an inch away, maybe 2 or 3 inches away. Let's see what we've got here. How's blood pressure? Perfect. Oh yeah, we're way too medial. Way too medial. So I'm starting to hit the spinous process. So I need to come out a little bit more lateral.
I dropped his tidal volumes too, and he's doing well with the low tidal volumes.
Fine.
Watch out.
And I can actually see his old incision here. And I'm more lateral with the old incision. Shot. Shot. All right. Shot. Seems like we're just miles away still. Shot. Let's get an AP. So we're going to use the front, back, and the side-to-side views of the X-ray to navigate the needle to get it to where we need it to be. We call that navigation, and it's fluoroscopically guided navigation, so it looks pretty good so far there. You always want the spinous processes in the middle of the pedicles when you're doing an AP view, which Monica's done a good job. You can see the endotracheal tube and you can see the screws and rods. All right, we're still a bit away. Huh? Shot? All right. Shot? Shot? Need to be a little bit more north. If you can show me that disc space a little bit better. Shot? Probably need to be a little bit more north. Shot. I'm starting to feel the scar tissue from the hardware from his prior surgery. Shot. Give me an AP. Again, we're going to go back and forth. And a little more medial than I want to be, but it's not bad. I can always come back more lateral. can clean that up a little bit. Shot. Shot. Getting close to those facets. Shot. And I feel the scar tissue from the hardware and the prior surgery. All right, AP. It's not bad. We're right there. I think we're off on orbit a little bit. Maybe a degree. See if you can find the orbital balance a little better. Huh?
Is that worse?
It's not about fuzzy, it's about where the posterior elements are. I mean, the exposure is worse. I think that's worse. Yeah, it's the other way maybe. You haven't changed the WAG, right?
No.
All right, we need to see that disc space a little better. You're still overexposed. Are you adjusting anything? I think that's worse. Let's try to look in through the foramen again. I think you're off on orbit. Just try something, try a direction and see if it makes it better. That seems worse, right? Yeah, go the other way. That's a little better. Try a little more. Just try another degree, see what happens. That's not bad. Try a little more, see if we can make it better. That's worse, right? Let's go back. We're gonna have to go back a little bit. That may be the best we can do right there. All right. Let's go back to an AP. Wait, let me just see if I can advance a little bit more. Any way you can show me the back of the disc a little bit better? Shot. Maybe it's a WAG issue. Try a WAG, just a little bit of WAG. We may be off on WAG by a small amount. See if you can get that disc space to look a little better. See, the one below is looking good. This one is kind of not, it's not as visible. So try the other direction on WAG. That may be a little better right there. Try a little more, see if you can make it even better. Huh?
Just checking to see where I'm at with this arm.
We're so close. What do you think, Luis? That might be as good as we can get it right there. I don't know. All right. Let's try an AP. So far, Los Pulmones are good.
Yeah.
What do you look for anyway, besides an X-ray finding?
Increase PIP, so increase pressure, so ventilation pressure.
Mm-hmm. You can clearly see that this is a lot different than the lower back. You know, we would be done with the lower back by now, but the thoracic is a much more difficult area to work in. And definitely up against the facet. Shot. Got a good trajectory, but I am too medial. Shot. I need to get slightly more lateral. Shot. Monica, I've got to get that picture better. I don't know what you got to do to make that happen, but I'm really struggling to see it. All right, I'm going to start a little bit more lateral. I'm sorry? Shot. That's maybe better. A little bit. Shot. Let's turn that light down a little bit. Its glare is in my eye. I've got to see that disc a little better, Monica. You see what I'm talking about? It's not far off. It's just, it's so close. Shot. What are you guys struggling with? The arm board? Then move the arm board north a little bit. Shot. I need you to get that disc so I can see it. You're moving the disc further to the bottom where it's coming out of the view. Okay, I don't know what you're doing, but I need.
The wave was helping it to look better, so it's come further, and I'll have to move more.
Yeah, whatever you need to do, get it.
You good?
You can't go north. You need to go south. You see the disc, right?
Yeah.
Right here. It's about to fall off the view if you keep going south. It was up there, now it's down there. That means you've gone too far south. Come on, I need you to make these corrections without me having to stop what I'm doing. If I'm focused on the x-ray positioning, then I can't focus on the surgery. I need you to do that part of the job. That's too far north. Yeah, definitely heading the wrong direction. That's a little bit better. All right, while we're working on this, if you have questions you want me to answer about this surgery or anything to do with the spine, feel free to type them up. In the meantime, Flynn, why don't you show our audience while we're working on this? That's better. Why don't you show our audience a video of why do people get back pain? You know, from a disc herniation or bulging disc. It's the annular tear, and it's not just the tear, it's the herniation within the annular tear that causes inflammation. We're going to keep working on getting into the disc while you show them that video.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, Submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. We're making slow progress, but we're making progress. We've had to reposition things a few times, and once again, I'm coming in from a different entry point and trying to target that foramen. Shot. I'm lined up with the disc better, quite well. I'm going to need an AP. I think I'm a little too medial. Let's see. Coker. Tell me when you're ready. Yeah, I'm just slightly, I probably could reposition. Stay where you are. Shot. So I went a little superior. Lateral. There's a lot to navigate through here, and this is the hardest part of the surgery, is truly the navigation. Once you get the navigation done, the rest of the surgery is not hard at all, but this is the hardest part. All right, I think I need to come in a little bit higher. Yeah, that's what I need to do. I need to come in a little bit higher. Shot. The trajectory here is everything. If you don't get the trajectory right, shot. And again, higher makes it harder because of the scar tissue from the prior surgery. Shot. 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 That's a little bit better. AP. Well, T2-3 is challenging to get to, but when you add hardware out there that I have to navigate around, it makes it even harder to get to. You can all see the screws and rods, yeah. I'm a little more medial than I want to be, so I'm just going to try to reposition and go a little bit lateral. Shot. A lateral view. It's interesting. I feel like I'm almost too far superior now. I need to move a little bit inferior. Shot. 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 Give me an AP. Seems to be better than the last time and the time before. Yeah. Let's keep going. Lateral view. So I'm aiming for the disc just below that screw. Many people call this adjacent segment disease, which of course it is. Shot. 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 That's pretty good right there, Monica, in terms of a visualization of that disc space.
And I think when he breathes, it's like every other
Shot. Yep. Shot. Shot. I'm just getting caught up on the posterior elements. AP. So we're right behind the foramen. Yeah, I'm going to try to go a little bit more medial. All right. Back to a lateral. I'm lined up nicely. It's just, can I get past this stuff? It's really the challenge. Shot. I don't think it wants to give me the pathway. Shot. Shot. Lineup is beautiful. We just need to get, oh, there it is. Shot. All right. Now, this is the super tricky part. You good? Give me an AP. So we're in the foramen, just entering the foramen now. You can see the screws above. You can see the disc space ahead of us. We're deflected lateral. You can see the needle is slightly deflected lateral. Let me see. Interesting. So, we may have to start even more lateral than we are. That's what we're going to have to do. The trajectory is good, but I need to go a little bit more lateral. Shot. Shot. I can see the disc, I can see the target. Shot. When you get pushed laterally by the posterior elements, you have to start more lateral, otherwise you're never going to make it. Shot. 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 I think we're too medial right now. Let's get an AP. Yep, too medial. So go ahead, lateral. So I'm starting more lateral, which is good, but now I got to work my way with the tip to go slightly more lateral than I am to get into that foramen. Shot. Shot. Trajectory looks decent, but I got to go a little bit more lateral. Shot. 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 Any way you can get me a better view of that back of that disc space?
Try one more shot.
Shot. Shot. Shot. I like the approach. I think I'm just too medial again at the tip. Let's get it one more AP. Patient's doing fine.
Yes.
No issues. Yep.
Ventilation pressures are good.
Huh?
Ventilation pressures are normal.
I may need to start a little lower. Our lineup to the disc is pretty good. I could be a little bit lower. I may have to move a little lower to get around the rib.
There's more scarring
Huh?
around.
Oh yeah, tons of scar. Shot. That's so close. Shot. It's really hard to see. Why don't you stop pulsing for a minute and just see what we can see without pulsing. Shot. See if you can get a better picture. That's it? That's worse. That's far worse. Wait, is that that's a pulsed picture or a non-pulsed?
This is a pulse picture, but I can do a little more.
No, I'm just asking. I mean, it's not terrible, but I want to see that disc space a little bit better. We're so close right now. And I just have to get it around these. That might be it, Sean. I think that might be it. Shot? Yeah, that's it. Shot? All right, let's get an AP. As long as they're not deflected.
I was thinking like you maybe move it a little taller.
Huh?
I was thinking like you move that needle a little taller to start there.
I may have to. All right, let's see what we can do with this. Stay there, yeah. Let's go back to a lateral. Again, give me a better picture. So I'm about a centimeter, 2 centimeters away. Shot. Let's get an AP. Again. I think I'm too lateral. Yeah. Go back to a lateral. I'm a good centimeter off from the disc on that view. again. And there, it's kind of hard to tell. Can you show me the needle tip a little better? It's hard to tell. It's really hard to tell. Any way you can clear that up? Yeah, that's better. It looks like we're a centimeter from the disc. And go a little bit further and just see. Shot. All right, AP. No, the lateral looks good, but the AP I'm not really entirely happy with. Yeah, we're still not close enough. So we're getting deflected. That's the problem. Let's see if you can give me a better AP. Get the spinous process in the middle of those pedicles. So you need to rotate it a little bit. Let's see what that does. Other way. Yeah, you can be fooled sometimes. I'd do a little more. Yeah, I mean the spinous process is still too close to the one pedicle. That's better. So that's probably a true AP at that level. And I think we're too far off. Yeah. I think we're too far off there. We're going to have to try again. So let's go back to a lateral. Huh? No, lateral looks good, but that's why you can't use one view. You have to do, it's three-dimensional. You have to reconstruct it three-dimensionally. Lateral looks really good, but the problem is we're being pushed. The needle is being pushed to the side, to outside the spine. So I'm just going to have to come in at a steeper angle, you know. Let's see this thing. Well, it's funny because it's literally right where my oh no, it's right where my initials are. Shot. 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 Once again, feeling the scar tissue. Again, 2 medial. Shot.
You say you feel that. Is it just creating resistance?
Yeah, a lot of resistance. And I can feel it's scar tissue. I know that's what scar tissue feels like. Shot. Shot. Close again, but shot. Just keep hitting those, the facet. The facet is enlarged.
Is that common with adjacent segment to feel hypertrophy?
Oh yeah. Oh yeah, the facets are going to be hypertrophy. That's it right there. I mean, we're so close again. Might be able to get it. Let's see. Shot. There is one other way to do this. We have to do it open. We'd have to open them up and then get the exposure and then bring the scope in. Shot. You know, kind of a hybrid open procedure. Shot. 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 We're right on the cusp. I'm literally as medial as I can get. Can you give me a better picture?
Another shot?
Can you give me like a clearer picture?
Try one more.
All right. I mean, give me an AP. Give me an AP. We're so close. Very, very close. Let's go back to a lateral. Those wires, guys. Wake up, Oscar. Mm-hmm. Shot. Shot. Give me an AP. Again, we may be fooled by the lateral once again. Lateral looks good, but it's all going to depend on the AP view. Again, we're just getting deflected. I need to see the pedicle a little bit better. We may be closer. I'm not seeing the pedicle. So you see that spinous process just medial to the needle tip?
Yep.
I need to see the pedicle that's there. I can't see it. So either increase your exposure or move your fluoro, do something, but maybe south a little bit. We just need to see those pedicle. There's the pedicle. Your spinous process, you need to adjust it, your rotation just a little bit. I think you've over-rotated. That's the other way. Yeah, you can see the pedicle right there. Can't see the one above. I can kind of see it, but I can't really see it. All right, I think we're too lateral there. Let's go back to a lateral view. Damn. One more. I got to see the tip of that needle. I cannot tell exactly where it is. Where do you think the tip is?
The brine is Monica.
Huh?
Change the brine.
Yeah, adjust the exposure a little bit. See if we can. I need to be sure where the tip is. I think I see it. It's still off the disc by a bit. Right? Luis?
Yes, I agree, sir.
Show us where you think the tip is. Yeah, that's kind of where I think the tip is too. All right. Well, I'm going to try to bring it a little bit more medial, and let's see what happens. If we can get there safely, we may be close enough. Shot. Feels something. Feels like the disc. Shot. All right, so I think we all agree we're at the disc, right? Huh? Well, I don't know, but it depends on what the AP shows. Let's go to the AP. I mean, on the lateral, it looks like we're in the right place. There is some rotation of the spine. There is an osteophyte there. You can see it. But as long as we've moved medially, which I think we have, we may actually be heading towards that disc. I could probably go a little bit further. Let's go back to a lateral. Any way to give me a better AP, by the way, or is that the best AP you can give me? All right, give me a good lateral here. Clean that up. It's too bright. It's way overexposed. No, it's not. It's not good. You're not shooting in the right place. Whatever you did, I don't know what you did, but you gotta, yeah, I think you're too far south. See how, yeah, that's interesting. All right, well, yeah, that's better, but it's still wrong. And we're off on orbit by about a degree. So if you can fix the orbit, that might be better. Hard to tell. Might be better. That could be better. Try the other way or something. Shot. Maybe. Try that. Yeah. That may be as good as we can get it. All right. Well, we're definitely at the level of the disc on the lateral, and I'm feeling something which feels like the edge of the disc. Shot. See, minusing the bone spur, this would be about where the disc is. Let's get IP again. So, I mean, we're definitely more medial on that picture. Rotate it a little bit. A little more. See, that brings the needle even closer. Other way. Yeah, the needle's right up against the disc. You agree? All right, now let's try. Go to a lateral. This is going to be our best shot to do it. We're right up against the outside of the disc on the AP, and we're also right up against the outside of the disc on the lateral. We might be okay. Let's just go slow and figure it out. Yeah. Again, we're off on orbit a little bit there. That might be better right there. Shot? Alright. Well, I don't know. Doesn't feel exactly like disc. Let's go back to an AP. Feels like we've gone through the end plate. Let's see where we are in the AP. Well, we're definitely in the spine, but I think we're inside the vertebral body. That's not where we want to be. We're going to have to back up a little bit. He may have some osteoporosis.
That's why it slipped through that.
Yeah. Let's go back to a lateral. Osteoporosis is going to make this even more challenging. Well, because then the bone becomes soft, almost like the disc. And you rely on the bone to be hard so that it creates a path of greater resistance so you avoid going into it. But when bone is as soft as disc, it shot. Really hard to tell. Really hard to tell. There is something else I can do. Just find out. Shot. Let's get an AP. If we are in the disc, at least in the beginning, then we can pull back and restart and redirect and try to get in to the disc. We're right there at the edge of the disc. Let's see. Shot. I can't even tell. You're way underexposed. Shot. Give me a lateral, please. I hope you don't think that's acceptable. Can you get a better picture of the disc space? Not much. Shot? I don't see anything. All right, well. I don't, that's not helping us. The dye's not helping us. I can't see anything. Shot. Give me the stylet, please. There's one last thing I can try. Again, the problem is I'm not 100% convinced we're in the disc. I think we're right at the edge of the disc. And this patient has probably soft bone. And that soft bone is really keeping us from being able to get into the disc. There is one last thing I can do. Should we try it?
Yeah. But why you so no? You don't want to go a little bit lower? Or you try that already? Or?
You think lower?
Yeah.
No, I like the angle of approach. I'll try caudal. I'll try one more. It's not a bad suggestion. Let's try it. Hey, I'm open to ideas. You got to get that disc better for me. You know, it's already hard enough surgery. I need you helping me with the x-ray. Shot? You're way off on the disc. Maybe you're wagged out or something, but it's not right. Shot? You had a nice clear disc picture before, and I need you to get that back for me. Shot? So we're going to try approaching the disc from a little bit lower down, since we're not happy with the upper thing. That's a little better. That's still not great. Shot? No, it's worse. Shot? Try to wag it in. I think you're wagged out. Shot. It's a little better. Huh? Less what? Oh, I'm hitting bone right now. I can't get past this. This is all posterior elements. Possibly some rib head. Shot. But I can keep trying. There we go. Shot. That time I got a little bit past it, but I gotta see the back of that disc. That's the problem. Monica is not showing it to me. Shot. So close. I feel bone spurs. I'm like right there. The only thing keeping me is the facet joint. It's literally the superior facet right there that's blocking access. So if I can get just, and that's what's pushing me over, is the superior facet. Shot? If I could just get past it, we would be golden. Huh? I can still see it. Literally just a millimeter. Shot? That may be it. A millimeter off. Shot? But a millimeter can mean everything. Shot? The difference between getting it done and not getting it done, you know? Shot? That's hung up right there. Again, hung up just on the posterior element. Same thing, you know? Shot? Yeah, I mean, it's so close. Let me think. Let's get an AP, just see where we are. Coker. So what's keeping me from getting into the foramen is there's a lot of arthritis. So when people get adjacent segment disease, it's not just the disc that degenerates, it's also the facet joints. And try to get it centered, that's better, but try to get a little more. That's worse. Other way. A little more. Yeah. So this patient's this patient's facet joints are the problem. That's why we're struggling. The adjacent segment disease has affected his facet joints to the point that they're enlarged, bigger than they're supposed to be. And when they enlarge backwards and sideways, and they're quite literally pushing my needle away from where I need to go. So they're blocking entrance. And we've tried maneuvering. Shot. That may be it there, but again, I feel like it's pushing me lateral. So let's see. Shot. All right. There is one more thing I can do. Shot. All right, let's go AP. Lungs are good. There's one more technique I could try to use. that I've used before, and it may work. It's to use a stiffer navigational tool. Oh, we're close. We're like right there again. But it seems like moving our entry and trajectory south a little bit did not help that much. So there is something I can do. Let's go back to a lateral. I'm going to try one more thing because I've tried every trick in my bag. You know, most important is getting your fluoro set up right so you could see the path as clear as possible. We're doing that the best we can. The next is using a little dye to see if you can figure out where you are, which we tried, that didn't work. The next is, of course, repositioning your entry points, medial, lateral, superior, inferior, and finding the best entry point. There is one more trick I have, and after that I'm out of tricks. So we'll give it one more try. Oh, by the way, we also have the trick of using general anesthesia, which with neuromuscular blockade and lung control, we've done everything humanly possible to this point. And I've never had to abort a thoracic, but we're close. All right, give me an AP. An aborted procedure means a surgeon can't do it for whatever the reason is. And of course, in the case of this patient, it would be, unfortunately, anatomical constraints, which is the anatomy is not conducive to do the surgery. So yeah, we're pretty much in the same spot we were last time. So here's my last ditch effort, and I will try it. I need a lateral view. So what else could be done for this patient? Unfortunately, the only other thing that can be done is a fusion, extending the fusion further down. And that's, you know, another major surgery, which he didn't want to do, and I didn't want to do, and nobody wants to do. Huh? And this works so well with his other herniation. But, all right, let's try and see what happens here. Again, for me, the most important thing is safety. I don't want to do anything unsafe for the patient. So we're going to try this and see what happens. So far, I feel comfortable doing what we're doing. It's safe. Shot. We're placing our guide wire. We're right at the back of the disc, but we're a little bit off to the side. So I'm going to make an incision, and I'm going to bring this dilator down, and we're going to see. The incision is 4 millimeters. It's tiny. And then I'm going to try, once I get the dilator where I want it, I'm going to try to reposition it. So I'll use the guide wire and everything we've done so far to get it as close as possible to the disc. And then I'll put it right at the back of the disc if I can, and then I'll drive it into the disc. Shot? Like I said, it's worked before, but it may not work today. So we'll just have to see. I'm feeling a lot of resistance now to the dilator because of the scar tissue. Shot? All right. Huh? Trajectory's fine on the lateral. It's not the lateral that's the problem. It's the AP. Shot? Yeah. Again, we're heading right for that back of the disc. Transforaminal. Shot? Everything's good. Cardiovascular? Yes. Lungs are good. Let's get an AP. Thank you. So I'm just, you know, so far we know the path we've created, which it's not optimal, but it's at least safe. And I'm bringing my dilator down. We're lateral to the spinal cord, and we're medial to the lung fields. And like I said, I'm going to try to leverage, like a teeter-totter, the tip of the dilator into the disc space if I can. Back to a lateral. By the way, typically the thoracic DLDRs are a lot easier than this. This is on a scale of 1 to 10, this is literally a 10 plus. This is the hardest we've ever done because of the prior fusion there. You see the screws and rods back there and the arthritis in the facet joint. The fusion creates obviously radiographic challenges, and then the fusion also creates scar tissue, which is pushing us in laterally as well. And then you've got the facet joint, which is really the biggest problem right now that we haven't been able to overcome. And that's pushing us laterally. Shot. So we're so close. Like I said, it's worth trying to do this and just redirecting medially. Shot. So my guide wire is out. Shot. All I've got left is this dilator, and I'm literally pushing it lateral so I can get more medial. Shot. We're right at the back of the disc, I think. Coker. AP. So it's as good as it can look on the lateral, but the medial is what matters right now. The question is, can I get it medial enough? I need a better picture than that. I need to see the pedicles. Huh? Yeah. Show me? That's not bad. I mean, the picture's not bad. Unfortunately, I gotta see the pedicle above.
Above it?
Yeah. See where the screw is? I gotta see that pedicle. I think you're over-rotated. Come back a little bit, maybe, or something. Try it. Shot. That's better. I gotta see that pedicle above. Can you help me see that? I think we're too lateral. Yeah. We're just not able to get medial enough. That's the problem. We're just not able to get medial enough. Give me a lateral view. One more. I'm right at the back of the disc on the lateral, and I'm not there on the AP. We can't do this, not safely. Well, we're gonna have to abort. I don't know what else I can do. Can you think of anything, Luis?
No, sir.
Yeah, it's not a bad idea.
Just asking about the diameter of the needle, the navigating needle. Do you have a gauge that's a little bit heavier on the navigating needle?
It's not that. It's hitting the bone and it's pushing the needle and like bending it lateral. And even if I go heavier, I still have to get through bone. You can't put a needle through the bone because that facet is probably like 3 times bigger than it normally is. So it's occupying more space, like a giant mass. And it's where you're supposed to slide just lateral to the facet into the foramen and disc. We're getting pushed wide. And I've tried all different trajectories. I've tried with the dilator. Huh?
Yeah, you went superior, a little bit more power.
It's just not safe, I don't think. We're just too far lateral to the disc. Yeah, go ahead.
Let me know.
Yeah. Yeah, that's good. All right, let's see one more time. One more picture. I hate to give up, but you have to know when to not go further, otherwise you'll hurt the patient. I just cannot get it. I'm like trying to lift it. I cannot get it more medial. Shot. They're right at the disc on the lateral, but we're not right at the disc on the AP. That's the problem. Lungs good?
Yeah, lungs are good. Yep.
Yeah, we've done everything we can do here.
Versus the dual horn, I guess.
Let's get one more AP shot just to look one more time. I'm gonna put this, what? What? Whatever you want, yeah. Monica can get a PACU. It's a good idea to get a PACU. Just to check the lung fields. You can do one fluoro in here with the lung fields, and then you see the pedicle there? We're just too far lateral. We're just too far lateral. We're not even, let me just try one more thing. There's just everything I've tried I cannot get. I'm hitting the facet shot. I cannot get it any more medial. Disappointing, but it is what it is. That's why we broadcast, folks. Sorry, but we're going to have to abort this thoracic Deuk laser disc repair. And the reason is, once again, the facet joint is just too big adjacent to that instrumentation infusion. The arthritic joints, they enlarge. If you've ever seen someone with an arthritic knee, all right, tell me when you're ready for the chest AP. Tell me when you're ready. You're going to have to zoom out, right? You don't want to be zoomed in. You want to see the whole field. So,
It's not magnified at all.
what?
It's not magnified at all.
Oh, okay, go ahead. Oh, looks good. Yeah, you can see the pulmonary markings all the way out. Yeah. So, sad we couldn't do it. What? Yeah, save it. Yeah, we've got it on the video too, so it's fine. And then we can get another one in PACU. Well, I'm sorry, folks, but this happens from time to time where we have to abort a surgery for one reason or another. In this case, it was due to anatomical constraints. The patient's facet is just too enlarged, and it's deflecting my needle, and that needle cannot get into the disc space. So you have to, as a surgeon, be able to recognize when you're entering a dangerous place that could jeopardize the patient's life. If I were to just proceed and not be in the disc, we would be somewhere we're not supposed to be, in the mediastinum of the patient. And that could, there's a lot of important things in the mediastinum, like the aorta and the heart. So we want to avoid injuring anything in there. So we're just, to be safe, we have to abort. We're going to have to figure out another way to fix them. Yeah, unfortunate. Type up your questions. I'll be happy to answer them for you. I'll be there shortly. I'm Dr. R. Deuk Majan here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I was, I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration where I could maybe get up, like stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No, I mean, she consoled me, and in the town that we come from, we know a lot of folks, and to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. And you can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser. And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are. And they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation. And how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the camera that what my personality is, but I try to be very polite, and I was apologizing for profusely sweating because I hurt so bad. It's not because of the Florida heat by any means, it's because I hurt so bad. I'd never experienced pain like that. And like I said, there's no
because you're a redneck too. You know, you're not that far from Florida.
That's
you're
right.
Just up a state or two, right?
That's right. Yeah.
A couple of states. So you're feeling better today. It's been less than 24 hours since
Yep.
we did your surgery. You went home an hour after the surgery, back to your hotel with your
Yep.
lovely family who I met.
Yep.
And how do they feel about your progress?
They're happy that I'm happy. You know what I mean? Because they were scared too. You know, now they were putting on a strong front, but I am just telling you, I was at my wit's end. And I certainly are a lot more appreciative of people who have pain that I'm aware of, because
Dr. R. Deuk Machen here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had zero pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L45, L5S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it off because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well. And I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Ari Deuk-Majin. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes,
How are you feeling today?
unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
No, absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you said, what are you going to do now? They said, I'm going to Disneyland. You already went, I can see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you, and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk-Majin. I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay. So you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Go on.
And is that because we have you doped up on powerful painkillers?
Nope. None
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep. Yes, they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while,
Yes.
but the symptoms came back.
Came back.
Yeah. All right. Well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. I did orthoscopic.
That's right. Arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. Very happy.
You're smiling.
Yeah. I tell you.
Congratulations.
Thank
Yeah.
you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
So now that your surgery's done, what are you going to do?
I'm going to go home and enjoy my life.
Good for you.
Enjoy my life.
Congratulations.
I am very happy.
Anything you want to tell your viewers?
Other than this is the place to come, it's worth the travel.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Deuk Laser Disc Repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk Laser Disc Repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk Laser Disc Repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk Laser Disc Repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk Laser Disc Repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk Laser Disc Repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk Laser Disc Repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk Laser Disc Repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk Laser Disc Repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk Laser Disc Repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk Laser Disc Repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk Laser Disc Repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two